Namaskar, good afternoon. I am Dr. Manish Bharti, Senior Consultant in the Department of Critical Care Medicine. Today we have a very important project on acute care bronchoscopy skills for the intensivist by the intensivist at the Sharda University. Let me introduce this concept of acute care bronchoscopy skills to you. This is one of the very important projects, the first of its own kind which is going to be done in this country, where we are going to collaborate with the Germany, Dr. Tushira Veeravarna and Dr. Rajesh Mishra, who is the IACCM, immediate past president, where three of us is going to work on the project of acute care bronchoscopy skills for the intensivist by the intensivist. In order to share further on this project, we have Dr. Ankit, who is going to help us in understanding through those questions and deliberations. We are going to go ahead and going to unfold this event for you. So we have Dr. Ankit. Dr. Ankit.
Hello, Dr. Manish. Thank you for giving me this opportunity to talk about this bronchoscopy. And we have learned so much about this bronchoscopy event. So let's talk something about this event, and we should discuss about this bronchoscopy procedures.
Yes.
So, Dr. Manish, can you tell me what is the acute purpose and what is the role of bronchoscopy in ICU?
I think it's a very wise question, Dr. Ankit, that what is the purpose behind having a bronchoscopy? So just to simplify to our audience and for each one of us, the bronchoscopy is a procedure where you're going to see the lungs, the windpipe, and you will identify any abnormalities which are related to the tracheobronchial tree. We are talking about the windpipe. So any patient who is having a disease of the lung, the patient where we expect the problems with the patient airway, there we try and we actually scope them. When I say scopy, it means we are going to go with the catheter, which is a fine tube bore catheters, through which we are going to visualize the airway, the lungs, and depending upon that what we are anticipating, what we are thinking about it, we take the call for it. If you're thinking on the line of infection, we draw the samples, we send it for analysis.
Yes.
If you're thinking about, let's say there is a foreign body, you withdraw the foreign body and makes the airway free from the impedency.
Okay.
Right?
So, as you are talking about bronchoscopy in ICU, so because we see patients ICU as acute care because they comes in distress, with some acute problem they used to come. So, how this bronchoscopy is different from other scopies
Now this
in
is
acute care?
I understand. Thank you, Dr. Ankit. Now, this is very important question that when somebody is talking about the bronchoscopy, then how bronchoscopy in the ICU is different from the bronchoscopy in the pulmonology unit. Now, we need to understand, Dr. Ankit, that bronchoscopy is a wide procedure.
Yes.
It can be done by the people from anesthesiology background. It can be done by the people from the critical care background, or it can also be done by the people from the pulmonology background. We are talking about the bronchoscopy skills which need to be done for the patients who are acutely ill, who are coming sick, who are coming with the lot of illness, especially the respiratory illness. So we are talking about those patients. So when they come to us and they have some respiratory disease, especially when they're having an acute disease, when they're coming acutely in the illness, we scope them, we take care of their airway, we remove the lungs secretions in case if this is leading to a problems in terms of the ventilation and oxygenation. So acute care bronchoscopy is very different from the bronchoscopy skills which is otherwise done in the bronchoscopy lab or the bronchoscopy suite or the one which is being done by the anesthesiologist for the management of airway. Now this is an important skill because we are in the modern era, Dr. Ankit, and we need to understand that modern era means it has a lot of evolutionary changes which has happened in the science.
Yes.
And now we have a better way to manage the patient airway, right? And we need to remember always that three things which plays a very important role for any patient who's coming in ICU is the airway, breathing and circulation.
Yes.
And the bronchoscopy is one instrument which is going to give you an opportunity to have a patent airway and to improve the breathing in case if the patient has issues related to the lungs.
Thank you, Dr. Manish. Very nicely he has explained about bronchoscopy, and we are doing this bronchoscopy in our ICU, Sharda Hospital ICU. Dr. Manish, can you tell me some acute indications where we use this bronchoscopy instrument and on which patient we use this bronchoscopy?
So thank you, Dr. Ankit, for asking this question. because this is something which comes to us by default. Okay, let's say why we are saying acute care bronchoscopy and what are those acute things. Majority of the times when we do scope the patients, either the patient is having the secretions which they are retaining. When I'm talking about the secretion, it's basically the phlegm, the sputum, which they are not able to expectorate out. And that's why it's leading to a mucus plugs, impaction syndrome, and their lungs get collapsed, right? They have atelectasis. So we are talking about mainly those cases. Let's say the patient is being ventilated. He's on ventilator. Now the patient has to come off from the ventilations. You got successfully extubated. Now the patient is holding on to the secretions, right? He's not able to cough them out. This is another indication. Third, nowadays it's a rampant practice to start every patient on antimicrobials, right? And many of the times, if you see the cultures which are coming up from microbiology, they don't support us, they don't help us in order to take the right decision, because colony counts get compromised. So all those cases are difficult to treat patients and to decide the antibiotic stewardship programs. If you have very specific sample for the specific segment of the lung which you are anticipating, you can actually help your patients to rationalize the antibiotics, the antimicrobials. Not only this, Dr. Ankit, we need to understand, we have a responsibility, huge responsibility for the rationalization of the resources like antimicrobials. We are somewhere leading to the invitation of MDR, XDR infections. So if you can limit the use of your antimicrobials, and there is a better way for you to understand your patient colonizations versus the infection, it's going to help your patients. And not only the patients, it's also going to rationalize the resources, plus the global burden of MDR, XDR pathogens, which otherwise is happening because of the indiscriminate use of antimicrobials. You can actually reduce them substantially. This is where I believe it's going to have a huge role.
Can you tell me just how, as you've told about bronchoscopy, in simple terms, if we talk in simple terms, can you tell the audience that how you initiate this procedure? What are the procedural steps in simple terms? Because as a medico, we know what all preparation, but if you want to explain to the layman, or if you want to take the consent to the family, how will you explain how you are going to do the procedure?
So thank you, Dr. Ankit, because this is very important question. I believe why? Because whenever you have any idea, you must know that what is the reason behind that idea. So in order to initiate the bronchoscopy, the first and foremost, there has to be an indication. You must justify the indications. You're not going to use a bronchoscopy for every second patient, but at the same time, every patient who is there in ICU, who need a lot of inputs in terms of ventilation, antibiotics, and all those kind of the stuff. In that situation, at least you should think, can I have a better diagnostic yield? So those kind of things, question should be there in your mind. So the first and foremost, there has to be an indication.
Yes.
The second thing is that, now this procedure, although it looks safe, but because you are doing this procedure for the patients who are critically ill, they already have a reduced pulmonary and cardiac capacity to compensate, right? So these kind of cases, when you're going to scope them, you can expect that there is a possibility of their oxygen level will go down, their hemodynamics, the blood pressure, the heart rate will go haywire. So it's a risk is much more higher in comparison to the routine bronchoscopy which happens in any other lab or the bronchoscopy suite. So you must take an informed risk consent from the family. Just you have to be very sure about the merits and the demerits which are attached to the procedure. You should be having a very clear plan that, okay, I'm going to do this thing. Let's say my patient is going to decompensate. How you're going to rescue this situation. So this is very important. The third thing, when you have done these two important things, now comes the preparation. So you have to prepare the patient, right? Your patient is going to slide for the bronchoscopy in a prepared format. Now, what do you mean by the preparation? Preparation means you have to numb the airway, because you are going to put a foreign body into the patient lungs. The patient is going to reject initially. So all those kind of things, you have to numb the airway. So you give them topical anesthesia, local anesthesia. Nevertheless, Dr. Ankit, let me tell you, this is very, very important. When you're going to do a high-risk bronchoscopy, you have to prepare the patient as if the patient is going to fall for the ventilation. So the family, as well as your preparation, has to be at par for the patients who requires the invasive ventilation. Because during the procedure, the patient can decompensate. And remember this thing, we are not playing with the simple patients. We are talking about the patients who are the sickest in ICU. So that is why you have to be very much well prepared, well endured. You must be having the gadgets for your airway, including the difficult airway cart. So these are the standard things which we do while execution of this one. The last and not the least, I always say when you're doing a acute care bronchoscopy, because we're talking about acute, where the patient has acutely got sick, it's a 3-man procedure. You need at least 3 people to do this kind of a bronchoscopy in a high-risk patient, which means the person who's going to scope, like you have been doing it a couple of times, I need to provide you an assistance in terms of your airway. The third person has to help you in taking the bowel sample. So it's a 3-man procedure.
Yes.
So these are the 3 or 4 important things which I believe should be reinforced on day-to-day basis, so that you can provide a safe environment for the bronchoscopy.
Okay. So as you told me that this is a high-risk procedure and it can lead to some of the complications, like patient may go on ventilator. So can you tell the audience that how much time the patient will, because layman can ask kitna time lag jayega isko recover hone mein, how much time it will take to come, just sometime collapse is there or sometime consolidation is there. So how much time it will take to recover if the family asks, or layman people ask how much time it will take to recover it?
So let me tell you, Dr. Ankit, I think one, the family, the physicians, the department, everybody must understand that you're not doing bronchoscopy for a reason where there will be just you did the bronchoscopy and now the patient will recover. It doesn't happen so. Science doesn't follow the arithmetic progression. 1, 2 + 2 4 नहीं होते science में. ये हमें समझना बहुत ज़रूरी है. Now why it is important? You need to understand that why the patient is needing a bronchoscopy. Do the patient needs a bronchoscopy for the primary indication for which the patient is coming in ICU? For example, mucus plug. Now the patient is coming in ICU for a mucus plugs. You did the bronchoscopy, it got better immediately, and the patient get better. Versus a patient who is having a multi-organ failure, liver affected है, kidney affected है, lungs affected है, heart affected है, वो ICU में है, and now the patient is developing something like a mucus impaction. Now these kind of cases who have a bundle of problems, multitude of issues, even if you scope them, they may get better as far as this bronchoscopy part is considered, but their overall tolerance to the procedure is dependent upon the cardiac reserve, the pulmonary reserve, and the other organ reserve which they are having. Okay. So bronchoscopy is not a tool which is going to create a Wizard of Oz, a magical wand, not like. So it's going to help you in sorting out any acute issues. Simultaneously, you have to take care of the other bundle care for the patient who is coming and who is sick in ICU. So that is where I see bronchoscopy is not the lone therapy which is going to change the outcome, but bronchoscopy as a part of good practices in the modern ICU, which needs good armamentarium. It works wonders.
Very nice. So as we have learned about this bronchoscopy, so in medical setup we receive all sort of patient, adult patient, pediatric patients. So in which age group of population is it helpful, like any particular age group, or we can do in all the age group of patients?
So I think this is a very genuine question. So I would like to say, Dr. Ankit, these kind of patients can be from all the age group.
Okay.
But as an expert intensivist in the adult intensive care, we generally do only for the adult patients. We don't do the pediatric right now, but you heard that when we were sitting in the meeting, we had a discussion that we are going to promulgate this program even for the pediatric intensive care, for the pediatric bronchoscopy skills as well. Dr. Amit is the person, Amit Vich is the person who is a part of this. And I think once we are going to establish this program in this institution, which we are already doing it, once there will be a more acceptance, we will have a good outcome. I'm quite sure that in a due course of a time, we will also expand our services to the pediatric intensive care critically ill patients who requires the bronchoscopy interventions as well. So as of now, we are doing mainly the adult patients.
So do you think this bronchoscopy will help in any diagnosis of the patient, or any like in complicated respiratory failure cases used to come? So is it helpful in diagnosing? As you are told, it's a well-known entity for therapeutic purpose. So can we use it for diagnosis purpose also?
Oh yes. In fact, Dr. Ankit, if you ask me, 50% of the cases when you are dealing with them for the bronchoscopy, they are for the diagnostic reasons. Now, what do you mean by diagnostic reason? Let's say a patient is not coming off from the ventilation, and you don't know the X-ray is showing you some certain kind of a shadow. We don't know whether this is consolidation or it's related to the mucous plug. You know that every day, every shift, the nurse is also doing a suction. So what you do with the bronchoscopy? It's a sophisticated suction. It's a sophisticated suction apparatus. You actually go inside the patient trachea, the windpipe. You see whether the problem which the patient is facing, is it because of the secretions, or is it because of the mucous plugs, or is it because of the blood? And once you are clear that, okay, this is the reason which is leading to certain sort of a problem, you can actually plan the treatment. If it is mucous plugs, you give them mucolytics, you take off the secretions, you shave off the secretions, the patient ventilation get better. Not only this, Dr. Ankit, this is very important, which I'm going to share in the next 2 minutes. When you are debating on day-to-day basis whether my patient needs carbapenems, polymyx cells, how you take the decision. Majority of the time, if you see, even in conventional evidence-based practice, I have seen multiple times, people are rationalizing the antibiotics on empirical basis, which is not a good way. So the idea is that you must be having a certain sort of a sample, which is objective and has a high quality yield. You take these samples into the consideration, which can be obtained by the bronchoscopy techniques, and then you sample it. So I have no hesitation to start the antimicrobials in a patient who is sick, but I definitely have a hesitation when you keep on endorsing the antimicrobials for nth number of days and your cultures and your investigations are not supporting it. And the reason why they're not supporting it is because you don't have a better yield. So the better yield you can obtain by doing a bronchoscopic samplings, because it's just merely a suction, right? You go into the specific part of the lung, suction, take the samples, send it, analyze, reports are there 48, 72 hours. You are more confident that the suctions, the secretion which you're dealing with, they're not coming from the upper airway or the contamination. They're coming directly from the segments in which you and me are interested.
Yes.
So it helps me in the diagnosis, certainly.
So if it is a so important tool in medical field, so this important tool, is it readily available or easily available in all of the hospital setup, or how it is important in the, because in routine setup sometimes it is not used because they use conventional methods only, suctioning and all that. So is it readily available in all the ICUs? Because you have worked in almost all the corporate sectors, you have worked in Middle East as well. So is it available everywhere?
So Dr. Ankit, if you ask my experience from the Middle East, NHS UK, they were the centers which have this thing by default. See, as long as you have a patient in ICU, you should have your bronchoscopy suit also in ICU. So there is nothing wrong to say when you have a patient, you need to have a tools to manage your patient. So if somebody is saying that I don't have this thing, then possibly it's difficult to justify the patient care in a holistic way, especially the patients who need bronchoscopic samplings or bronchoscopy for the diagnostic and therapeutic reasons.
Yes.
Especially in the modern evidence-based practice. Now, I'm not saying and I'm not endorsing that you cannot do the ICU practice unless and until you have a scopy. Bronchoscopy. We are not endorsing this thing. But what we are saying, if you're trying to provide a good holistic care to the patients, you need to have all the armamentarium ready for your patients so that you can serve them better. Right?
Yes.
So that is how I see it. Majority of the good setups, modern ICUs, they have all this kind of equipments. There you don't have to think even. But yes, and now you have seen that even at Sharda Hospital in the last 1 year, we have done almost 250 bronchoscopies, which is making us sit here together and discussing on this project to the extent that it has been appreciated by the people outside the country. And that is the reason why they are collaborating with us, because they can see that the kind of volume which we are able to generate in terms of the better quality of diagnostic yield and the better patient care is phenomenal.
So as a medical personnel, if somebody want to learn about this bronchoscopy, so is there any particular courses there or any fellowship is there? Like if somebody wants to work and want to learn this very good procedure, so how he can be trained himself?
So I think, Dr. Ankit, you have a very valid question, and that is why we are sitting here together. So let me tell you that we are having a first center of its own kind in this country, which is going to train the people, especially the intensivist, for this bronchoscopy skills in ICU. We are talking about ICU, right? So as of now, the dedicated training modules or the dedicated training centers for ICU-based bronchoscopies are not available. But I'm
Okay.
sure once we have conceived this idea and we have this vision, we are going to multiply. So as of now, the pulmonology-based ICUs, they're doing in the bronchoscopy labs and the suits, but we are talking about the ICU-based bronchoscopies. The dedicated training is, unfortunately, is not available. And that is the reason why we are embarking on this, because we know that there is a gap and we are trying to fill up this gap.
So we want to fly high in
We want to fly high.
in this mission, and we can invite our new doctors so that they can come and join us and learn this
For sure,
beautiful procedure,
for
right?
sure.
Yeah.
And you have seen, Dr. Ankit,
Yes,
like
yes.
you, me, and Dr. Sharma being together in the last 1 year. If we can do it together, anybody can do it. We started from the scratch. We
Yes.
just need to be associated with the right people. And very soon we are going to start the services
Yes,
with us.
yes. So after doing all this research work and all, is there any specific contraindication for doing this procedure? Specific?
You must know how to select your patient, Dr. Ankit.
Yes.
Remember this thing, if you're doing this procedure, which requires high level of training, let me acknowledge this fact. We are not doing a routine bronchoscopy. We are talking about acute care bronchoscopy skills where the patient is actually sick. So definitely there has to be a certain indications as well as the contraindications. So you have to be skilled enough. The absence of a skilled operator, the person who is not experienced for doing this acute care bronchoscopy procedures, they should not handle it.
Okay.
You will have maximum mishaps. And then for the reasons which we know, the bronchoscopy per se will receive the blame.
Okay.
Where actually it is the man behind the machine which is making the difference. So it is not the problem related to the bronchoscopy. It's a person who is playing with the bronchoscopy. You must know how to play with the joystick.
Very good.
It's a joystick. So you must know how to play around, and that is what we are going to train them. You certainly have to limit the time for which you are going to perform the bronchoscopy. Generally, acute care bronchoscopy, we don't do it more than 10 to 20 seconds at a one go.
Okay.
So we try to limit the duration. And certainly a patient who is coagulopathic, high FiO2 settings, the patient who is difficult airway, all those kind of cases, we have to be very cautious while scoping them. That doesn't mean they are contraindicated.
Okay.
In modern medicine, the indications, the absolute contraindications are decreasing. The relative contraindications are increasing. The indications are increasing.
So as we are going to start this acute bronchoscopy care in Sharda Hospital, so we have learned so much about this procedure. So is any research paper is going on this because we have seen COVID also in the recent past years. So any specific research, any specific paper or study is going on this?
A lot of work is happening, Dr. Ankit. It's just that your mind need to identify the papers. If you're finding the paper, if you're trying to find out the papers in the favor of bronchoscopy, you will find them.
Okay.
I'm going to share. In fact, we have shared this presentation as well, that we have a lot of the papers which, especially with SARS-CoV-2, where the people have done bronchoscopy and they discovered almost 80 to 85% of the airways, they had mucus secretions. So I think it's certainly important.
Thank you, Dr. Manish, for giving us such an enriched experience about this bronchoscopy, and we have learned a lot from you. Thanks again. Thanks.
Thank you, Dr. Ankit. And let me tell you, I would like to acknowledge that Sharda University has given us the wings when it comes to this. And within a short span of less than, I would say, 1.5 to 2 years, we have been able to multiply not only locally, but also nationally and now internationally. So this is what, I want to submit in the last. So thank you for watching us and thank you for being with us. Thank you.
Thank you.